So we let's moving forward. So next we will have Dr. Kilpatrick to give us talk on the CGM. Dr. Kilpatrick is the Fayetteville, Arkansas native, and she got a degree from UT Southwest, and then get residency and fellowship in Washington University in St. Louis. And she actually started the endocrine program in the Washington Regional Hospital in Fayetteville. Right now she has 3 partners, and she very active in the local medical society, and she serves as the vice president, and she also co-founder of our organization ADEFO, and as a vice president. And CGM is very important in our everyday practice, but we still have lots of questions, confusions, and she put a really great talk. Let's listen to the talk.
Okay. Good morning. I came here from Fayetteville to talk to you guys about continuous glucose monitoring, so my favorite topic. I appreciate you all being here for our first one of these meetings. This is really exciting for us. And I don't know if Val mentioned in the little handout deal you have, there's a QR code. Did you talk about this? There's a QR code you can go to the schedule and you can link to all of the slides. And then there's a survey, which I don't know if the link is working, but you'll all get all your CGM for this. So we're going to talk about CGM. My talk is going to be a little bit of a transition from what you have heard this morning. It's a little more touchy-feely, kind of, and that's just how I roll. So these are our learning objectives. I'm going to provide you an overview of continuous glucose monitoring systems, the most common ones available. I'm going to show you a little bit of evidence for CGM as a tool for better glycemic control and as a potentially life-saving device for your patients. And then I'm just going to go through quickly, a way to sort of just a basis for looking at these reports, because they can sometimes be a little bit intimidating if you're not used to looking at these things. Okay? First things first, why did we do this organization in the first place, right? Well, you guys all know that there's a huge issue with healthcare disparity, especially in the South, especially in the rural South. So equipping primary care with the ability to understand how to manage diabetes and how to manage endocrine disorders is really super important. Diabetes affects 1 in 10 people, and it's on the rise, probably more than that by now. And so knowing about this technology and all of these details you've heard about this morning is absolutely so important. I know in Northwest Arkansas, where we are located, there are 7 of us, and the area is growing. The growth in Northwest Arkansas outpaces the entire rest of the state, so it's total insanity. So this is just an emphasis on how important this is for primary care to understand these things. So the touchy-feely part of my talk here, right? So diabetes is a difficult disease. And it is, I kind of argue it's like none other. Maybe heart failure is sort of similar, but you have to kind of think about diabetes every moment of your day. So it's estimated that somebody with diabetes has to make at least 180 decisions per day pertaining to their health, potentially. Obviously, that depends on how involved they are in their care and how maybe aware they are, have they had diabetes education, and do they understand the implications of their choices. Do they make choices to take their pills? Do they make choices to eat? Or what are they not eating that maybe they should be eating? Are they exercising or aren't they exercising? Are they checking their blood sugar at all, right? Are they bringing it to their appointment? Who knows? Probably not. Are they getting enough sleep? Sleep is one of the most common things that I actually talk about with my patients, and the lack thereof leads to metabolic disease. Are they taking their insulin and their shots? Are they having a cocktail? Are they in college? Are they going out to a party? Who knows? So all of these things impact our patients, diabetes care decision-making. It drives them crazy. So this is really just here to acknowledge that we try to rationalize in our jobs the normal physiologic process that our body would be doing for us if we didn't have diabetes. So this is just kind of an acknowledgement, because your patients, right, they come in and their A1C is, oftentimes like a reflection of how good or bad they are maybe. And this is just kind of to acknowledge, I'll actually hand this out sometimes when patients are like, I don't understand, I eat breakfast this day and it's this way, and the next day it's this way. And I'm like, this is why, right? Because we're trying to rationalize something that is not normally something we can see. So it's a big process. So the history of diabetes, I think, is the most fascinating piece of medical history, right? 100 years ago, type 1 diabetes was universally fatal, right? And the way in which we checked blood sugar has transformed. I would argue nobody in here today has patients checking their blood sugar by peeing on a stick, right? No, that doesn't happen yet. So it's mind-blowing what has happened. Is it gonna work? Okay, we have a video that might play.
When I was 4, we had our testing kit. We would take 5 drops of urine, 10 drops of water. We put a pill in it, in the little tube, and then a pill under it, light a match and burn it. And then you would shake it real good and count to 5. I don't know about that. And then you would match it to a card that had different colors on it. So I match. And that's how you knew if you were high or low or in between. As I got further along, they had a piece of tape that you would urinate on. And it would turn colors. And you would match it to a color chart. Later, we got little sticks, little plastic sticks with stuff on the end that you would dip in the urine and test that way.
Okay. So that's Brenda. She's my patient. She's 79 and she's had diabetes for 75 years. And so just sitting and talking with her was the most fascinating piece of science. I've got to go and pick a video of this woman and catalog her story. But the point I want to make here is that the standard of care has changed. And the standard of care is becoming, if not already, CGM. So what is a continuous glucose monitor? It is a small device worn on the top of the skin. Here we go. And glucose is checked within the interstitial fluid by a thin filament that is inserted into the subcutaneous tissue. And depending on the brand or which device we're talking about, it's monitoring blood sugar between every 1 and 5 minutes. So simple, it goes on. I tell patients it's like a sticker. It seems sort of intimidating at first, and then you just peel it off and throw it away when it's over. So these are the 3 most common that you may be aware of. So the Freestyle Libre 3 system is here, the Dexcom, and then the Medtronic. The Libre I'm going to go through as well as the Dexcom. For the purposes of today, I'm not going to go into the Medtronic. But these are the ones that, I would say most of those of you in primary care are probably pretty well heard of and are used to and have prescribed in your practices. So I'm going to go through the nitty-gritty details of the Freestyle Libre 2, 3, and then the Dexcom 6 and the Dexcom 7, okay? So bear with me. So these are nice little pictorials of the Libre 2 and the Libre 3. All of these devices have evolved over time and have become easier and easier and easier and less intimidating for our patients. So the Libre 2 and the Libre 3 are very similar. The Libre 3 has all of the features of the Libre 2 and then some. So for the Libre 2 and the Libre 3, they're both indicated to be worn on the back of the upper arm, okay, for 14 days. There's no calibration required, so the patient puts it on, scans the device to activate it, waits an hour, and then within an hour they are able to use the device. 14-day wear. It's an all-in-one transmitter. So again, you put the sticker on, when you're done, you peel it off and throw it away. Simple, easy peasy. You can have the device the receiver device, or you can have the app on your phone. This is the app for each of the respective devices. It's a different app for each one. We always encourage our patients to use this device on the phone in order to facilitate remote monitoring, of course. That just makes our lives easier. You can also have followers through the Libre Link Up app, so you can invite followers to see your blood sugar. So from a safety perspective, that's really nice. Water resistant for 3 feet and up to 30 minutes, and can provide real-time alerts. So a low alert, a high alert, and then a signal loss alert, so the patient can know if they're not protected. The low alert, you can set it whatever, 70, 80. Some of my older patients on insulin set it, kind of a higher threshold. The Libre 3 has the same, capability, but there's no scanning required and no scanning involved in that device. There is a receiver available only for the Medicare patients at this point. And so importantly, these devices can be prescribed at your pharmacy. So it's very easy, right? 2 sensors per month. If your patient is on insulin, in most cases, they're going to be covered by insurance. Medicaid covers, type 1 diabetes for sure. Medicare covers for your patients who are also on insulin. So becoming more and more attainable, and I think there's more acknowledgement that these devices are very helpful for our patients with diabetes. Next, we'll talk about the Dexcom system. So this is the other kind of big one. These are a little different. So this is the Dexcom 6 and the Dexcom 7. So the Dexcom 6 is actually a 2-piece system, wherein you have this gray transmitter piece that kind of pops into a sensor that's put on separately. The transmitter is good for 90 days, and then the sensor comes off, you separate the pieces and put on a new sensor to pop in the transmitter. The 6 is worn is approved for 10-day wear on the abdomen. The Dexcom 7, which is actually an all-in-one transmitter, is approved for 10-day wear on the back of the upper arm. So it's all-in-one, put it on, throw it away after 10 days. Also, importantly for people who have patients with type 1 diabetes, currently the Dexcom 6, right, as of now, is the device that is integrated with the Tandem X2 and the Omnipod 5 pumps. There is no scanning required with either of these devices, so they automatically read to either the receiver or the phone, and they both do have, as you can see here, the apps for the phone. And so again, we encourage all of our patients to use it on the phone if possible. It is water resistant up to 8 feet and 24 hours. And you can also similarly have 10 followers through the Dexcom Follow app. The Dexcom 6 there's a lot of alerts within the Dexcom system. It kind of takes a long time to go through it. So there's a high alert, a rise alert, a low alert, a fall alert, so if you're falling really fast, a signal loss alert, and then a predictive low alert. So if you're going to be low less than 55 in 20 minutes, it will tell you. Within the Dexcom 7, there's a little bit more capability with the alert. So let's say you had a muffin this morning, right? Okay. You got diabetes, or pre-diabetes, as in my case. And you can make your blood sugar go pretty high, but maybe you know it's going to come right back down. You don't want to know it's 200 immediately. You can delay that first high alert so that it's not like driving you crazy. Alarm fatigue is real, you guys, you know what I'm saying? People stop using their device because they get tired. Use the nose. They get tired of all the alarms. And then the tethering of the rise and fall alert. So I don't really care if my blood sugar is rising by 3 milligrams per deciliter per minute if my blood sugar is 60, but I might want to know that if my blood sugar is 250. Similarly, I don't care if it's falling quickly if my blood sugar is 300, that's the point. But if it's 70 and falling, then I might want to know it. So a little bit different in terms of what's available from the alert perspective here. Same thing in terms of coverage. For people who are on insulin, no calibration is required. One difference with this one, I didn't put it on the slide, is you can calibrate the Dexcom if that's something you want to be able to do. You have that capability within the app. toward the receiver. So as I said, these devices have evolved over time, right? Like the first, finger stick blood sugar monitor machine, Brenda talking about it was like this giant thing, And as time has gone on, I can remember when I was in fellowship, however many years ago it was, putting on all the devices and how like terrified I was of some of the things. And I'm like, what do I do? How do I do this? This is real easy, right? You can just look at this and know. So this is the Libre 3 and this is the Dexcom 7. You unscrew it and you pop it on. It's easy, right? So even our grandparents can do it. That's the important thing. So easy to apply. And then I want to make a plug about getting followers. I love social media. It's one of my favorite things. I have a social media account for my professional life. But I want to argue that actually encouraging your patients to have followers is a really important part of their care. When I see a patient who has type 1 diabetes or an older patient and they are, say, a college student, one of the main things I'm asking during their visit is we're asking about alcohol, we're asking about birth control, and we're asking about who knows about your blood sugars, who are you hooked up to so I can know that you're safe, right? So this really does make a difference for your patients, and it's an important capability potentially of these devices. So what is the value of CGM for us in practice and for your patients? You guys know that A1C often does not necessarily match the blood sugars. On Thursday, I was on the phone with an orthopedic clinic about my patient's surgery that I said, yes, she can have surgery. Her A1C does not match her blood sugars at all. She is actually well controlled and can proceed. Patients have variability, and I'll show you that in a minute, that affects their quality of life, right? This is a disease that carries a substantial life burden, and we cannot appreciate that with just an A1C. We see a decrease in hypoglycemia. If you know what your blood sugars are, you're less likely to stay potentially in a hypoglycemic event. You're going to know that you're having hypoglycemia and be able to treat it. And what I love the most is right here. Provides immediate feedback to your patient for the opportunity for behavior change. So one of my first patients in practice, many years ago, I put her on whatever CGM device I had at the time, and she's still on a CGM to date. She's type 1, and she just pops in my mind. She's like the perfect case. She's got A1Cs between 11 and 12, long time, when she came to see me. She's on prescribed medicine, 25 units of Lantus and 7 units of Novolog pills or something, whatever it was. I did nothing for this woman except give her a CGM. That was it. She's not really giving me like a great history anyway, right? And so since that time, her visits are pretty similar, but now her A1Cs are all between 6.7 and say 8, okay, consistently, no matter what I'm doing and no matter how I'm advising her. And why is that? Because she had the tool to modify her behavior. She knew what her blood sugars were, and she wasn't scared anymore, right? And so, life-saving alert. So I would argue that part of the reason that patient probably takes her insulin now, she's not as scared as she was before. So we know that A1C, as just going back to this, does not always match what the blood sugars are. There's a lot of reasons for that. I have similarly patients that I see chronically and know their A1Cs are going to look great, and in fact, their blood sugars suck, and so like trying to help the patient understand that these don't always match. Sometimes I'll check the fructosamine level, but really I'm looking at the CGM and what are the actual blood sugar numbers. That's what I care about. And then I mentioned the quality of life thing, and just to kind of re-emphasize that, these 3 patients with an A1C of 7% have very different qualities of life, right? You can appreciate that. The glycemic variability of doing this all day, drives people crazy, makes them, have potentially fear. Maybe this is a metformin-only patient, maybe these are some insulin patients, who knows? But, this is kind of more stressful, obviously, than this. And being able to appreciate that as a provider is so important. And then, convenience, not having a finger stick, like, there's so many reasons, to use these devices. When I was in my first couple of years of practice. As CGM has become more popular and virtually everybody is on it now, patients would come in and they've got like blood all over their sheet. Maybe they wouldn't have their blood sugars written down, or they all end in like 5s and 0s. And I'm like, I don't really believe this, right? So you're capturing this data and you're missing so much as a provider. Patients on insulin having, hypoglycemia unawareness, they're just not aware of what's actually going on. They don't feel it anymore because they've, had it for so many years. And then again, just the glycemic variability that's associated with, quality of life issues is huge. So what about CGM as good as medicine? If I'm sitting across from somebody, I'm all about multi-drug therapy. But if I'm looking at somebody and I'm thinking, what else can we do? Are you already on max whatever good drugs we have? Then why are you not on a CGM? Why didn't I think of that already? Why can't we get this? What's the issue? Is there a financial issue? So there was I have a meta-analysis here, just I'm referencing A1C decreases by, maybe 0.5 to 0.6 compared to finger stick monitoring in patients with type 1 diabetes. We see this similarly in patients with type 2 diabetes. A1C reductions on the order of 0.9 to 1.5%, depending on the study that you look at. There's many, many studies looking at this. And as you guys know, taking care of patients are not statistics, right? And they run the gamut. So patients that, like the one I referenced before, whose A1Cs are always better, there are similarly people who don't like the devices, don't want to wear the devices, and don't necessarily act on the devices. So I do think it really depends on patient engagement and how they treat the technology that we've given them. And then life-saving alerts, right? So being able to have that hypoglycemia knowledge is so important for our patients in terms of feeling comfortable taking their medications. So this is an AGP report, an ambulatory glucose profile. This is taken from the Freestyle Libre, and you can hook these up to your practice, right? We downloaded them a whole lot when we were in COVID. Of course, we download them every single time somebody comes to clinic. I'm just going to quickly run through the AGP report. So I go through this with the patient very briefly in clinic. I'll tell them, hey, here's your average glucose, and here's your time in range, right? So here's the time in range. And Dexcom, by the way, has a similar AGP report that's similarly one page that looks like this. What does the ADA say about time in range for our type 1s and older type 2s right here? So, standard patient you're seeing, middle age, not too many medical problems, time in range of 70%. The older adult who is very complicated, lives alone, maybe takes insulin, has COPD and heart failure and who knows what else, time in range of at least 50%. So there are different standards that I think we got to be aware of too. And then pregnancy time in range, I'm not going to go through this, but just notice that the time in target is 63 to 140 versus when we're talking about typical time in range, it's 70 to 180 time in range. Okay, so pregnant people, we want it way more tightly controlled. Next, we have the average glucose here and the glucose management indicator. So this is just an estimate of the patient's A1C, just like the patient I was on the phone with the orthopedic surgeon's office, telling them, no, it's okay, everything's fine. Her blood sugars are actually better than her actual A1C. And I have proof here of that. And then the daily, this pattern, this overall kind of overarching average pattern that I like to look at, gives you an idea of the patient's overall glucose sprawl, where they might be having obvious trends that are high. Okay, every day they have a bowl of Cheerios, maybe we can do a little dietary modification. And then finally, the daily glucose profile on the bottom. So although it's small, it is set at midnight to midnight here, so you can kind of see, depending on your patient's schedule, where things are happening. You can see a better breakdown too in the reports that print out day to day and have a good conversation with people about how to adjust maybe their insulin or whatever, how to adjust their behavior, what are they eating on Tuesday night and bowling, like maybe pizza and beer, obviously it's gonna go really high, right? And then there is value with these devices looking at the data on the patient's phone, even if you don't have any of this in your clinic. So if the patient has a Freestyle Libre, you can go into the reader or onto their phone, and there's a whole bunch of different statistics you can pull up. I just picked 2 of the screens here. Similarly, on the Dexcom, if the patient has the Clarity app on their phone, which is the sort of like statistics app for the Dexcom, you can pull off the time and range, the estimated A1C, and a complete report right there on the patient's phone, potentially. So a lot of utility there. And then finally, the challenges of CGM are real. So just getting our patients used to using technology. Skin reactions, Flonase nasal spray all the way to the skin before application is what we typically do. Bleeding, I've put on CGM before, and that's spurted blood. I don't know, like maybe I have a little tiny artery. That's really frustrating for people, and they want to talk about it, with you, the provider in the clinic. Sensors falling off. That's probably the biggest reason that patients don't want to use the devices because they are tired of paying for something that they can't get to work. I tell them, please call the company, they'll usually replace it. We encourage skin tack. You can buy it on Amazon for like less than $20 for 50 wipes. The over tapes that you can buy third party also on Amazon for all the devices. And then the Dexcom does come with like a overlay patch for both of the devices that they have available as well. So a lot of these logistical issues are things you guys spend time working through with your patients. And then you guys have all probably had people who sit around and check their finger stick blood sugar, and then they look at their Dexcom or their Libre and they're not the same number. Dear God, please don't do that. If you feel like it's off, you should check, but there's going to be potential differences. We liken it to a train. If the blood sugar is rising quickly, there's going to be lag in the sensor glucose. So the finger stick will be higher. If the blood sugar is falling rapidly, there'll be lag in the sensor glucose, so it'll be higher. When they ask, what do you do about it? It's a case-by-case thing, right? But if you sit around and check both, you're going to drive yourself crazy. And there is some normal variability between these 2 devices. And finally, CGM is something that is paid for, right? So as a provider in endocrine, we can, patients coming in, we can look at their CGM reports, do interpretations and make medication changes with this, and bill a 95251 code, potentially. Okay, so easy to prescribe, potentially. For your patients with Medicare, just one more comment. As long as the patient is on insulin, that the rule is now that they should be able to hopefully get on one of these devices through Medicare. But I hopefully showed you that CGM is becoming the standard of care. It definitely provides value for our patients with regards to glycemic control and safety, and just provides us a whole lot more information than that, theoretically, the numbers that the patients would have written down in the past. So hopefully with time, medications are getting better, the technologies that patients are using to track their blood sugars are getting better, and it's going to make, in the long term, hopefully our lives a whole lot easier. That's all I have. So now we have a coffee break.
No, we still.
No?
Oh.
Yeah, we have a coffee break.
Oh,
yeah.
Yeah, I'm sorry.
So I think what we'll do probably is push our lunch just maybe 30 minutes, so we have an hour allotted for lunch. So we'll take a few minutes coffee break. What do you think, Val?
Yeah.
30 minutes?
Yeah.
I don't know if we need that much time, but okay, well, we'll take a coffee break and then we'll come back after the next 2 lectures, then we'll have lunch. And thank you guys so much.